Now I have to say to you when you replace. I think more and more I replace. The old people now, no doubt, I go to replace because I think the result is more satisfactory. The possible solution for this kind of fracture have many: bipolar, total hip replacement. The good thing, most of these fractures come over 80s. Then it's easier to decide to replace. If you look at some evidence, the operation after internal fixation is 35, and after hip replacement, 9%, almost 1/4. And the mortality looks the same, a little more with the hip replacement, and the pain, function, and quality of life, no difference. But you have to evaluate all the patients. If the patient's good shape, playing golf, like some guys here, then you have to think about what to do. But after 8, really, I think you have to decide more to do the prosthesis. Because you have high incidence of complication, about 20 to 40% of revision after when you do fixation, and about 8% of AVN, avascular necrosis. The morbidity and mortality are advantage, and internal fixation overcome with much more complications. Where to improve the internal fixation? It's not easy because you have to have stability, you have to good stability and good fixation, but you have to operate early. Sometimes it's not possible, mainly our hospital. Then you have to operate. When you compare hemiarthroplasty, total, bipolar, in displaced, look at this. Bipolar may be more operation, and total hip replacement, better function. The comparison is very difficult because different type of prosthesis, different type of patients. If the patient there is dimension, non-walking, then you have to choose different type of prosthesis to use in this case. When you compare unipolar, bipolar, monoblock, modular, looks the same. Some a little more expensive, but the result looks the same. You have to think about the non-cemented and compare with the cemented hemiarthroplasty. If the fracture is displaced, there are many papers talking about to do after 75 years, after 80, to go direct to prosthesis. The mortality rate is equal, but the internal fixation, you have much more reoperation than when do arthroplasty. Look here, 23% internal fixation and 3% hemiarthroplasty. And go more, reoperation after 1 year. The satisfaction and function is favorable to arthroplasty, and the mortality is equal. The problem is the patient. You have to choose better the patient to decide age, comorbidity, and then you decide to go to fix or to replace. But the age and activities, really, it's very important to decide that. There are really few studies after 2 years and after 8, but you have really show many papers that after 10 years, 9% of total hip replacement, they are in good results. But if you do that before 60, you lose with the time. 95% with 5 years, 94 with 10 years, 8, 9, 15 years, and after 20 years, you lose. If he's younger, you have results much less good than when you do after 80s. Look at this patient, the hybrid, have to evaluate the bone to do. This randomized comparison, displaced fracture, the mortality rate equal, reoperation after 1 year, internal fixation, almost 40. Total hip replacement, almost 10%, 4 times less. If you know cognitive deficit equal to active patient, then you can do like a young patient. But if you're more than 40, and there are a lot of comorbidities, alcohol, corticoids, rheumatoid arthritis, then you have to think about to do some Hemi. If you resume, you need more prospective studies, but total hip replacement is superior than internal fixation. The final recommendation, you have to look at the age, you have to look at the patient. If less than 60 and ASA 1 or 2, you have to think about internal fixation. Less than 60-year-olds, but the ASA is 3, you have to think more about total hip replacement. 6 to 80 years, really difficult phase to decide, but ASA 1, 2, and 3 may be total hip or Hemi cemented. If 6 to 8, ASA 1 or 2, internal fixation. After 8, really you have to think about some kind of prosthesis, depending on activity of the patient. Thank you.